Thank you very much for this nice welcome. Just to confirm, this goes till 12:50, including Q&A. Is that on your schedules as well? Just want to make sure I don't go over my time. 12:50, okay, and that includes questions. We'll be fine. So thank you for that nice introduction to you and everyone else. It's a real honor to be here, and it's so nice to meet colleagues. Dr. V has left, but I wanted to comment to her and her colleague how refreshing it is for someone like me who specializes in another part of this sort of, this sort of care team. It's so nice and refreshing and informative to hear about research about hormone management, which is not something I do directly. I defer to my colleagues with expertise. But a lot of all of the observations you mentioned, I've noted in my own patients. So I really also want to second her big point, which is that we need more science behind this. Because there's a lot of inconsistencies. Some people do, some people don't, and it's sort of teasing that apart is so important. And it's only with science that this field is going to really evolve and progress. So anyway, so today I'm going to talk a little bit about kind of the sort of program-related issues with transgender care. I'm speaking to an educated audience. We're going to talk about terminology and the usual stuff. This is sort of about some of the challenges and needs that I've encountered in starting a couple of programs, insights, and then a little bit about some clinical unknowns and so forth. I don't have any real disclosures in conflict with this talk. I consult and stuff, but nothing in conflict with this talk. We'll talk a little bit about genital surgery care guidelines. This may be old hat for some of you, but there's always some that haven't really seen this. And can everyone hear me okay? Yes. Okay, good. And then I'm gonna give us some overviews of the surgeries. I think it's important to kind of understand what we're doing on the surgery side. So we'll do that, and then I'll talk about these sort of programmatic challenges and insights. I'll talk about the design of our own program. Ours is just, a program, but I've put a lot of thought and effort into designing it, and I just want to share, what I'm trying to achieve with it. Then we'll talk about some clinical unknowns and controversies, and then some opportunities for innovation. I think all of our lectures, these forums, we have to always hit on, we got to look to the future, bring this field forward, just like any other field of medicine, which is thankfully what it's really being recognized to be today. So treatment in need, everyone here knows that gender dysphoria, what it is, and that it can be treated and alleviated with treatment. The point of this bullet point is that surgery is a part of it, but not necessarily for all. Many transgender patients don't need any type of surgery. Some need surgery, and some need, there's different types of surgery. It's not all about genital surgery. That's all I do. But it's important to recognize that there's a spectrum there. And I think it's also important, just like with any other care in this field, it has to be, about helping the patient on an individual basis, explore their identity and affirm their identity, and to find a role that's comfortable for them. And again, patients may prioritize surgeries differently. I'm not going to talk about terminology with one exception. I think it's important to lead by example, and there's all these terms for quote-unquote sex reassignment surgery, gender reassignment surgery. I call it gender-affirming surgery, just because if we've learned one thing in the last 15, 20 years, since the 70s, when, for example, sexual identity has been looked at and kind of moved from the realm of pathology or disorder to just part of human variation, human diversity, is that we don't reassign gender. Gender is as fixed in all of us, I think, as our sexuality is, and all these other things. So it kind of sort of makes me cringe when I hear gender reassignment. It's like, it's a very paternalistic term. I think what it means is that the medical community is reassigning the patient's gender, but even that is sort of ridiculous. So I think care and terminology should be, or terminology just like the care we give should be patient-centered. So terminology, I think gender affirming is the most patient-centered term that I've heard of. I was the first, to my knowledge, the first to be using it, at least in San Francisco. But I just think it makes sense, and I think it's a good opportunity for us to lead by example. So the professional care guidelines, I'm sure everyone here knows what WPATH is, the World Professional Association for Transgender Health. But for the medical students in the audience that may not be familiar with it, it's sort of the leading professional organization worldwide for transgender health. And the beauty of WPATH is that it's comprised of care providers and scientists, for lack of a better term, social scientists, pharmacologists, pharmacists, etc., of all disciplines that contribute to transgender health. If you go to a meeting, you'll see people from every discipline of health and science there. So it's really nice. And their mission is really, what I think is very important, that we promote evidence-based, outcomes to guide treatment. So it's it's an important organization. It's an understatement. They publish guidelines, which you can easily access online. It's a big PDF. It's free. It's in I think 20 or 30 languages. And these guidelines are just guidelines as far as WPATH is concerned. They're not laws or anything like that. But to share with you as a surgeon who interfaces so much with health insurance companies, these guidelines are by our U.S. organizations, insurance, Department of State. They're adopted as sort of de facto requirements now. So they actually are requirements, even though they're not WPATH's requirements. They're now our own U.S. organization's requirements. So Medicare and Medi-Cal, who cover transgender care, defer to WPATH guidelines and requirements for, among other things, surgery. And I'm going to go over those guidelines in a second, but that's why they're important to know. I think one other subtlety that sometimes doesn't get mentioned when people talk about WPATH's guidelines is that WPATH themselves, it's implicit that there's inherent flexibility for these guidelines. These guidelines are written for a global audience, and WPATH members recognize that care in the U.S., there are different constraints than care in Europe or South America or in other parts of the world. So, it's okay to bend these guidelines a little bit to sort of serve communities and to work within, different governments and laws and so forth, and cultural norms. Let's go over, I'm going to go over the guidelines in a second. Let's go over the surgeries. I think it's always important to include people who identify as gender non-binary too. This isn't a binary-oriented talk, but since I'm talking about surgery, it's sort of easier to kind of categorize these as masculinizing and feminizing and masculinizing surgeries. So with that said, from top to bottom, the general classes of surgeries are facial feminization surgery, vocal cord surgery, breast augmentation, body contouring, and genital surgery for feminizing surgeries. And for masculinizing surgeries, it is, I think it's very uncommon. I don't really see it often for men to get facial surgery. Maybe it's facial surgery not for gender-related stuff, but people have a funny nose or X, Y, or Z. Maybe they'll get it, but it's not a common component. The more common options that people take are mastectomy and then genital surgery. And I'll go into those in more detail in a second. So the criteria to have surgery, in the lay public, I'm always asked, so I can just walk in and, sort of ask for these surgeries. Of course not. I'm a big believer in interdisciplinary care. So when we provide surgery, it's always within a context of multidisciplinary or interdisciplinary care. So people, the guidelines from WPATH dictate that patients, to be eligible for this, should have undergone at least a year of social transition, which is full-time life in the gender they identify with, living in that gender, at least a year of hormone therapy, and then 2 referral letters from mental health professionals. These don't have to be from psychiatrists, they can be from any mental health professionals, but they can't be from a surgeon or from the primary care doctor or whoever's prescribing the hormones. They have to be from mental health providers. And again, this is so important because it may not seem like a big difference to us, and to be honest with you, I don't prefer to the letters, I go by my own opinion, but when I submit for pre-authorization, the insurance companies will deny stuff if they don't have their letters, and if they're not written by the right people. So it's important to do that. I will say this, as a member of WPATH and someone who's contributing, to the guidelines, the new guidelines will come out in about 2019. This is probably something that's going to be different, where it's probably going to be reduced down to one letter. Because I certainly know from personal experience, it's very onerous for patients. They have to get 2 letters, it's expensive, and so forth. So that'll change. Again, flexibility and thoughtful design are important. So let's shift gears and talk a little bit about the surgeries. These are somewhat graphic. To follow up with Dr. Bierwicker's many great points about hormone therapy, I think it's so important to emphasize the value of bilateral orchiectomy for patients. It's now not uncommonly done, but it's not nearly as commonly done or offered as I think it should be. So there's unequivocal medical benefit. It allows patients to discontinue spironolactone, which we've heard some of the potential harmful effects of that, and other androgen blockers. It lowers their estrogen dosage, which, although the details remain to be defined, how this, to what degree dosages and what dosages contribute to cardiovascular disease, there's no question that it's better to be at a lower dose, at least for cardiovascular health, than a higher dose. And this is especially important for women who smoke or who have a DVT history, personal or family, or who are on very high dosages of estrogen. There's benefit to this. And also in my own experience, I learned so much from patients. I have a gender dysphoria inventory that I give people, and people after orchiectomy simply say they feel better, like right afterwards, just not having testicles in the scrotum. It gives the scrotum a very male appearance. It's part of the little icon of the penis, and not having that is sort of lowers dysphoria. It's easier to tuck, and no one's really talked about one of the many interesting areas that I think need to be explored is the effects of testosterone on mental health and some of these other factors that Dr. Bierwicker importantly pointed out. So anyway, there's good benefit to this. It's a 25-minute surgery, skin to skin. Patients I do it on an outpatient basis. And if it's done correctly, and by that I mean by in any way that doesn't create problems for vaginoplasty later, it's fine. So since I do vaginoplasty, I do both male to female and female to male surgeries, so masculinizing and feminizing. So, I do vaginoplasty through a midline incision. So I make if I'm going to do an orchiectomy for a woman who, let's say, has to undergo 6 to 12 months of hair removal, I say there's medical benefit if it's at least going to be 2 or 3 months till you have surgery. You can get an orchiectomy ahead of time, and there's no problem. You start enjoying the benefits early on. So I do a midline scrotal incision at the top of the scrotum, which is going to be incised anyway, and I get both testicles out through that. I'm careful to support to preserve the fat pedicle that's on the medial underside of the spermatic cord. Because, I use that to support the labia majora later with vaginoplasty. And they go home the same day, and you can stop, quickly taper down spironolactone to lower their estrogen. And typically after orchiectomy, women do just fine, with about half the estrogen dose that they were on pre-treatment. So, and again, I defer those dosages and management to my experts like Dr. Bierwicker and whoever's prescribing hormones, but that's what I've observed. So I'm going to get into the options of vaginoplasty, but let's suffice it to say there's about 3 options. You can create a vagina with a vaginal canal that allows the woman to have receptive intercourse with either a male partner or a toy or digital, and something can enter her, or vaginoplasty without a vaginal canal. And then there's intestinal vaginoplasty. Those are sort of the 3 broad categories. For vaginoplasty with a canal, they're actually all the same except the canal part is the only variant. What we do in the surgery when a woman's having it all done at once is we do bilateral orchiectomy, creation of the vaginal canal space. You know, in the genetic male pelvis, there is no space between the rectum and the bladder, where a vagina is in a natal wound. So we have to create the space. The best tissue to use to line the vagina is the penile skin, because it's already got its own blood supply. Many women are circumcised, so that becomes an issue. That's why we do some variants. But we use the penis skin, so we separate the penis from its skin, save the skin, and save part of the urethra, and then remove the rest. We shorten the urethra, create a neoclitoris that's sensate from the penis glands and the neurovascular bundle, the nerves that run along the top of the penis. And then I do scrotoplasty to basically create labia majora and minora. For some reason one of the pictures sort of chopped off here. There's 3 pictures at the bottom, but we go from sort of natal male anatomy to female anatomy. The far left panel should just be with this patient with her legs up but not spread. When the legs are up and not spread, you don't see the clitoris because it lives under a little hood that we make for her. But it's basically, it has natal, the appearance of natal anatomy. This is a 49-year-old woman, 5 months after surgery, with vaginal depth of 5.9 inches. So you see a little perineum, the vaginal opening, I'm looking at the far right panel, a vaginal opening at the bottom. The urethral opening is at the bottom of that pink tissue. The top of the pink tissue is a little discolored because she had a little bit of granulation tissue, which we treat with silver nitrate in the clinic. And then the clitoris just up top, and that's about it. A post-op course, they're in bed. If the woman's going to have a vaginoplasty with a canal, they're in the hospital for 5 to 6 days. So the day of surgery is day 0, and they go home at post-op day 5 or 6. I'm pretty conservative, but I have very good outcomes. I've not had a vaginal prolapse or a rectal injury. I keep women on bed rest. I think the neovagina heals and settles better without a lot of movement. When we stand up, the pressure from our belly pushes it down, and it kind of squashes and sort of telescopes downward, and that's why I think you get prolapse. I've never had a prolapse. It's a little bit frustrating for them to stay in bed for 5 days, 4.5 days, but it's worth it, and everyone does fine with it. I put a vaginal packing in. The 5th day, I remove the packing, help them have a bowel movement, and then we take the catheter out, the urinary catheter, and then start dilation and douching. I think it's very important that when we do these surgeries, the surgeon provide all the equipment that the patient's going to need. The last thing a woman needs to do after surgery is to worry about where am I going to get the dilators, life happens and then they don't dilate, and then it's stenosis and you have a lot of problems. So I provide all patients with a little, like a care basket that's got the douche, the dilators, lube, some gauze dressings, everything to get started, and not have to leave the house for a bit, so that we just focus on self-care. One of the interesting things that I've also noticed, like Dr. Vieriger's made lots of interesting observations, I'm fascinated by the fact that about half of my patients go home on just ibuprofen. I don't understand that, because in all male surgeries, male genital surgeries, that where we do a fractioning of what we do in this surgery, men have a lot of pain. But when you remove the same structures and more, my women patients seem to have much less pain. I'm not quite sure why that is. I think dysphoria, exactly. I have a sense for why it is, but it's very interesting, and people don't, that's not talked about a lot. So anyway, another option is intestinal vaginoplasty, and people have heard about this. There's some myths about this. It's often billed as like a self-lubricating vagina. Well, yes and no. First of all, what is it? We take a piece of bowel, and we use that to line, to be the vaginal canal. So I make the space, and then I take a piece of bowel, and I put it there. The end of the bowel deep in the body is, of course, closed, and it's not in continuity with the stool. It's removed from the intestine, but it's still connected to the body by its blood vessels. And then the other end, the end outside, is right at the vaginal opening. And it's wonderful because it provides a nice, soft a nice soft vaginal canal with excellent blood supply. It is self-lubricating, but it's not like lubrication. I'm sure everyone's heard about the peritoneal vaginoplasty and this and that. I think there's a lot of, I don't believe that it creates lubrication, and two, it certainly doesn't create it on demand, like arousal. And a lot of women come to me thinking that when they get aroused, their vaginas are going to get lubricated. No, it's sort of a little bit like a runny nose. The intestine is, as far as it's concerned, it's still intestine, and it makes a little bit of mucus kind of forever. So I warn, counsel patients, you have to expect that. But it's just clear, like mild when you have a runny nose, and it's not a problem, it doesn't smell. But women have to expect that. And I reserve this surgery only for women who've either lost their vaginal canals, it's stenosed and it's gone, or for women who have really no skin to use. So they were circumcised and have very short penises and have very small scrotums. When a woman is circumcised, if she wants a canal, we can use the penile shaft skin, which on a circumcised person with a penis is only about 2.5, 3 inches. It's not enough for depth, for satisfactory depth. So what we can do is use scrotal skin and then cut the skin off or leave it attached to the body and then put it as a cap for that little short tube of penile skin. And then you have a nice long skin sock, if you will, and then invert that to get a good depth.
Is there a difference with performing the surgery of someone who did not go through
yes.
puberty, male puberty, and
yeah.
so they didn't experience any growth?
Yeah, that's a very good point. So, today, just to shift gears a tiny bit, and again, I think this needs to be better studied, but a lot of, I've certainly observed, and some of my colleagues in WPATH have observed this, is that people who are on women trans girls who are on puberty blockers as kids, they don't have that surge, that hormone surge in the body that gives growth to the penis. And in many ways, that when they're children, that's a good thing. The problem is they grow up with very small genitals and not a lot of skin. So those are people who we do need to make these sort of moves to get skin from somewhere else to make it up. Okay, one more question.
If you use the scrotal skin to increase the length of the vaginal canal, is that skin sensitive? Is it as sensitive as it is as a scrotum?
Well, it depends on how it's used. If there's two ways to use scrotal skin. If a woman has a long scrotum, what I always favor is leaving the bottom of the scrotum, the part of the scrotum near the perineum, and leave that attached to the body, so it still has blood vessels and some nerves. And then I take that long, it looks like a big tongue. I take it and I sort of sew the end of the penile skin to its end, to the end of that tongue, and then I sort of make a tube out of the whole thing. So then it's attached. I favor that because it's got its own blood supply. The other way of doing it, and what I see more often from my colleagues, but I also do it occasionally too, is I remove the scrotal skin completely from the body, and then put it on a little patch to the penile skin. The benefit of that is that if she has a very short scrotum, you can still use scrotal skin, but if the scrotum is short, it's not going to be a very long tongue, so it's not going to get a long canal. But if you detach it, you can still get good depth. Does that make sense?
Yeah.
But when you detach it, what I don't like about that is that it's like when you buy lawn and they just put it on your lawn on the dirt. It has to grow and get blood vessels, and if it doesn't, it's going to fall out. So I see a lot of women, and it's happened to me too, where when I use scrotal skin grafts, sometimes in my hands, about 10% fall out, and it's hard to. So that's gone down for me. I leave them on bed rest longer, but that's the risk. So to move on, I do intestinal vaginoplasty as a salvage surgery. Primarily, almost exclusively, or for the occasional woman who just has very little skin everywhere, and we really just need to bring fresh tissue in. And it's got excellent cosmesis. It feels very nice and natural, and it gives excellent depth. Because the colon segment is longer than she'll need for sex. but you know, some of the long-term, you know, some of the long-term consequences of this are a little bit unknown. I do recommend that they get, when they get colonoscopies, when they get a little older in life, that they also get, you know, they have the surgeon put the colonoscope in the vagina as well, because that tissue is still subject, as far as it's concerned, it's still colon and can get colon cancer. So I think we have to be, you know, first and foremost, be very careful. I know it's gender dysphoria inducing to have that, but we just have to do it. And I tell them that up front. And I think when people expect it, you can make a gender dysphoria inducing procedure sort of empowering, because it lets them just take control of their health and say, we're going to do this, let's do it whole hog, and be careful down the road, and this is just going to be part of your healthcare maintenance for life as a woman, and people are very accepting of it. And then my sort of, one of my favorite, I don't know, like Skype, I'm very happy with this. Okay, so this is one of my little, peeves. You know, I think that a lot of surgeons don't talk about this at all or enough. So what is zero-depth vaginoplasty? This is the third option. It is basically an identical vagina to one with a canal, but one without a canal. And I tell women, you can't tell them apart unless someone is literally poking, trying to put something inside. But just by looking, you can't tell them apart. So it's identical. It just doesn't have a canal, and it's a good choice for women who fit different profiles. Patients for whom dilation or douching is overly burdensome, people with neck or back problems that can't bend over to douche. It's less common, but it can happen. I had a woman with MS that just didn't have good manual dexterity to dilate and douche. More commonly in my patients, it's women who have exclusively female partners and don't want to deal with the hassles of dilating and douching forever, just to have a canal that they aren't necessarily going to use for sex, completely or at all. So, we have to ask about how people, anticipate what their needs are, and then just give them options. I always emphasize, the last thing I am is the decider. You're the decider, but help me answer my questions so I can give you as many options as I can, so that you can make the best choice you can. But maybe a third of my patients request this. And I ask them, and it's rare that they'll say, I'll ask them, has anyone else offered you this? Because patients often see more than one surgeon. And almost always they'll say, no, I was just offered vaginoplasty with a canal. So, skin and scrotum and this and that. So I think it's important to offer this. It's actually a challenging surgery, making the little, so where the vaginal opening would be, I make a nice dimple. And that, from a reconstructive standpoint, for it to look nice, is hard. But I tell patients when we're talking about it, and a lot of patients have sort of this feeling like, well, it's not a real vagina, I'm not a real woman if I don't have a canal. I always say, if a imaginary woman were to lay down on this exam table and part her legs, can you tell how deep she is? No, you can't. The vagina is what you see. So I show people this little, this series of plaster casts. They're from an artist near where I trained in England named Jamie McCartney, and it's called The Great Wall of Vagina. And you can find it online. And there's about 300. And they're plaster casts. The artist, I met the artist, and he told me he had a handful of trans women, but he said 97% were cisgendered women. And the point I always make with these is that, look, they're all very different. And if we want to define natural, these are all quote-unquote natural. These are cisgendered women. They all look different. Some have big floppy labia, some don't. Some this, some that. And you're going to be somewhere in the spectrum of normal. I'll tell you up front, I can't make big floppy labia because you don't have enough or that kind of skin down there. Frankly, most women are quite happy not to have big floppy labia. But and I say that not, that's not a judgment. I mean, it's never a problem for them. Is all I mean when I say that. But there are limits to what we can do. I can't make something where there's nothing. But they have totally normal looking vaginas. And secondly, you can't tell how deep any of these women are. And that's life. I mean, that's reality. So, I think I've observed that some a minority of transgender women suffer from the same thing that many men suffer from, and that is the sort of concept that, big penis, big man, and that in order to have a real vagina, it has to be deep just because it has to be deep. Not necessarily. A vagina is, it depends on how you want to look at it, really. But I think it's important because it can affect health and your lifestyle, your ability to care for yourself. Women who've had HIV, which is people are at higher risk for anal cancer, and have had rectal radiotherapy, they're another group that I tend to emphasize much safer. I won't do a vaginal canal in a woman who's had rectal radiation, unless it's an intestinal cancer, because that whole area is affected. Anyway, suffice it to say, they go home, post-op day 3 or 4, and they recover well. And interestingly, every woman that I've done this for has been extraordinarily happy with it. No one, I always offer them, I say, look, after this, if you have any doubt, and after zero depth, we can always do an intestine. I've not had anyone come back to that.
Do you women get good elasticity with the estrogen benefit after the surgery? Or do they get that estrogen benefit?
That's a very good scientific question. I think it's hard to study because how do you measure, elasticity?
Well, just in the reporting that they're able to accommodate their partners better than they expected to without surgical length,
Oh, in cisgender women?
No, in your trans women that worry they don't have enough depth, but are on
Oh.
estrogen and estrogen cream.
Oh, I see.
and
No,
things.
I see. So that, just to repeat that.
Well, you're good.
Your mouth.
Yeah, okay, so, sorry. That's a good question. How much more, let's put it a different way, how much more depth can a woman gain over time with dilation? I really don't think it's much at all. I think that the best thing that they can do, I think there's a little bit of added depth that people can achieve, but it's not much. The reason is that when the vagina is made, the canal is made, it's a skin flap or graft. It sort of starts to take to the body, and that's what it takes to itself is not all that flexible. It's skin like on our arms. I mean, you can't do this to me, right? So it's the skin is not that flexible. Now, if you use scrotal skin, that I think you can get more because the scrotum is like, scrotum or labia are very stretchy, but not a penile inversion vaginoplasty. But I think it's important to preserve depth. So when I do vaginoplasty, I measure the depth at the time of surgery. I tell them you are exactly this many centimeters up to your introitus, period. Let's work on keeping that. And if you dilate diligently, like I show you, you may even gain a centimeter. It's not going to be much more. And I think it's important, I think it's very important to tell women not to try to dilate too aggressively. Because what happens after vaginoplasty, the stitches at the opening often tear. And I think it's because if you push that sock in too deeply, it's going to come apart the only place it's anchored, right at the posterior fourchette. Does that make sense? I learned that's a lesson I learned after I started. And that's why I put a mark on their dilator. I've actually designed a new dilator douche combination, but it has marks for depth so that women know exactly where to dilate to. How would any of us know how deep to dilate? Because you can't see it, right? It just goes in and disappears. So it's, anyway. So common questions after vaginoplasty, can I have an orgasm? The answer is yes. All of my patients that were able to have an orgasm before surgery. One of the lessons in medicine is that pre-intervention function is predicted best by, post-intervention function is best predicted by pre-intervention function. So yes, 100%, and that's 100% gospel truth, I've been able to achieve orgasm by around 8 weeks, whenever they're comfortable touching themselves. Erogenous sensation is present in and around the vulva. It's typically not enough to get an orgasm, but I had a couple of patients who lost their clitorises. They weren't my patients. I didn't do their original surgery, but their clitorises got infected, and basically, one, I finally just debrided it off. It turned to nothing. And she was still able to achieve orgasm by stimulating her vulva, which had no clitoris. So I think it's possible. The brain does miracles to compensate for things, but it is at least erogenous. The quality of the orgasm, my background is in sexual medicine, And so I pay a lot of attention to this. Half of my patients say it's as good as before surgery, and the other half say it's better than before surgery. And if you ask the ones that say it's better, most of them will say it probably feels just as good, but to me overall, it feels much better to have an orgasm with the body I was meant to have, one that I didn't have a relationship with. Average vaginal depth, it varies. The minimum I strive for is about 4.5, 5. 5 is my preference minimum. How long is the average erect American penis? Does anyone know? Just to make sure everyone's awake.
5.5?
5.5 inches. 5.6, 5.7 inches. So, it's not always enough completely, but it's certainly very functional. I tell women, be careful what you ask for. A vaginal depth of 7 inches, how are you going to keep that clean? There aren't douches that are 7 inches long. And, there's no exit up front. And it's not, it's not unlike a natal vagina, it's just lined by skin, so there's no mucosa to make secretions, that the secretions dribble out in a natal vagina. Not in these, so it's not dissimilar to an armpit. It's warm, skin lined, and kind of there's no exit, so you got to keep it clean. So something to think about. What happens if I stop dilating? I always emphasize 12 different ways that vaginal stenosis will happen and will lose the vagina. Is the vagina self-lubricating? No. That's one of the few little differences. It's lined by skin. There is pre-ejaculate, which comes out of the urethra, which can be lubricated, but otherwise, no. On that point, we don't ever take out the prostate. There's no need to, really, and it's very small, and taking it out has a lot of risks that are involved with it. So I'm not aware of any surgeons that do that. I certainly don't. And satisfaction is always very high, even in people that have complications. Male to female to male surgeries. Take-home message, I don't want to make this, I want to speed this up, but female to male surgery, the take-home message is that it's staged typically. I do phalloplasty in 2 stages, not 1. I think outcomes are better when we break it up. In the first stage, I make the penis and the urethra. There are different ways to make a penis. You can do a metoidoplasty, which is not a full-size penis. It's using the clitoris. That can be with or without urethral lengthening. And then to make a full-size penis, we can use, I think the gold standard is the radial forearm or the anterior thigh. Radial forearm, I think, is better. And then there's tummy skin that we can use. The drawback of tummy skin is that it has no sensation, and you can't make a urethra from tummy skin. And in the first stage, I do that with a plastic surgeon, microsurgeon, that joins the vessels and nerves together, and he raises the flap on the arm. And then I make the penis and the urethra and put it where it's supposed to be. Second stage is typically about 4 months later. That's when we do all the other stuff. The vaginectomy, the hysterectomy, if he hasn't had that done. Vaginectomy, I join up the urethra from the native opening to the base of the penis. I'll show you what that means in a second. And then I make a nice glans for the penis, and then maybe put a testicle prosthesis. And then about 3 months later, if there's no infections, I'll do the penile prosthesis. So here are some pictures. I'm not going to, in the interest of time, I'm going to just show I think the best one, the radial artery forearm flap. It's one single flap of skin from the forearm. It's not totally circumferential. I leave a little strip of skin here, but everything else is taken. And from that, I zip off a little bit of the skin, as you see in the middle panel, so that it has no skin, and that sort of serves as a hinge and lets me roll up the narrow rectangle as the urethra, skin inward. And then the bigger rectangle is the shaft. That's rolled kind of like a belt, the opposite, skin out, and that's how you get a penis. On the top right, that's the penis still attached to the arm. And then we disconnect it from the arm, and I prepare the recipient site, and I put it down there, and you see in the bottom left, there's a blue catheter. That catheter is going not into the bladder, but into the little urethral opening I put just at the base of the micropenis, or the clitoris, what used to be the clitoris. And that's just a hold up, penis opening. And there's a little wound drain at the top, kind of like that, Penrose drain. As far as I know, I'm the only surgeon that offers harvest of skin from the buttock. Men often get these split thickness skin grafts we have to cover the arm, because now you have an arm with no skin. So I get the skin from the buttock. I learned this in England. It has good cosmesis. I'll show you in a second. But I take these 2 tongues of skin and then just kind of, they just get, you know, the incision line is at the bottom of that little buttock crease, so you don't really see it. Cosmesis is generally good. Can you see the scar? Absolutely. And that's the main reason why a lot of men opt not to use the arm, because it's visible. A lot of men get tattoos though, and that can look good. And then here's the glands later after surgery. So here's a penis that's healed after the first surgery. It just looks, for lack of a better term, kind of just tube-like on the right, on the top left there, sorry. And then that's the urethra after it's healed. These pictures are all 4 months after the first surgery. So the first 2 are at the beginning of the second stage surgery. And then the one on the top right is at the end of the second stage surgery. I've made a glans, there's a catheter in the urethra now, and then I've made a scrotum. There's a little fold there, but he got a very nice capacious scrotum. And I bring the bottom of the labia majora up, and the tops, sometimes I bring the tops down. And then of course I bring the sides together in the middle to keep a nice sac. And there's a nice glans at the end. Patoidioplasty, I think most people know what that is. You know, what used to, the micropenis, what used to be the clitoris, it gets virilized and a little bit longer, it gets a little longer. It's not huge in length, but this can be certainly done nicely to make a small penis. Here's a good example of how the tops of the labia are brought down. Notice on the top left, the labia are kind of where they are in birth, but they should be, the scrotum should be kind of just at the underside of the penis. So I bring them down and then I put 2 testicle prostheses. And they look very, very nice. You know, patients are in the hospital for 7 days. We've not had a phalloplasty stay after 7 days. They go home, we have a nice pathway to work and so forth. Common questions, you know, can a man achieve, you know, if it's done, if we use the arm, can you achieve orgasm with the penis? Yes, the secret to that is twofold. One, at the second stage of surgery, I move the clitoris, the micropenis. I take the skin off and I move it and leave it right at the underside of the penis, right under the skin, so that when he either masturbates or penetrates, there's literally rubbing on the skin right over the head of the clitoris. He can't see it because I peeled all the skin off and buried it, but it's right under the skin. What's interesting is that, and the second thing is that, so people have 2 clitoral nerves. I cut one of the clitoral nerves, and we connect the sensory nerves from the arm. For the medical students, the medial and lateral antebrachial cutaneous nerves. We connect the sensory nerves to the clitoral nerve, which is already wired to the brain for erogenous sensation. So a transgender man who's had this surgery really has 2 sources of erogenous sensation in the brain. The old clitoris, the micropenis, which has now disappeared into the penis, and then all the skin from their arm skin that is wired now directly to the brain. So I published this in 2014 in England, when I was in England, or after I got back from England, but with penetration of just half of the penis, so excluding the part that's got the old clitoris, 60% of men can have an orgasm. That's just, that to me is mind-blowing, but it's not 100%, but that's pretty high. So it's just, there's so many things we don't know, all the remapping that happens at the level of the brain. It's just fascinating. I'm starting a study at Cedars looking at brain imaging with sexual stimulation before and after surgery as well. So again, satisfaction is very high. And doing all that stuff to the micropenis, or what used to be the clitoris, doesn't seem to in any way diminish its sensitivity. Yes?
You have a question, erectile.
Yes, I didn't, I have not mentioned erectile function. Well, I did in this other slide. The very last thing we do is put prosthetics in, because prosthetics can get infected. But at the bottom, stage 3 surgery, we can put in a penile prosthesis. And I strongly favor, I generally kick and scream if anyone tries to make me put a malleable in. I favor inflatable penile prosthetics, because inflatables have a very low profile. I've seen men with malleable semi-rigid prosthetics, and they end up getting kind of like a saggy bag of skin as the penis. Because the malleable prosthesis causes a lot of necrosis of the fat, and sort of like in someone who's had breast implants for decades, eventually you can see the implants, right? All the fat around the breast is dying. The same principle happens in the penis. There's necrosis of the fat. So you want a device that has a low profile and only gets bulky when needed. And unless someone's having sex several hours a day, most of the life of penile prosthesis is not being used. So that's better. Insurance coverage. California state law in 2013 made it illegal. Legislation made it illegal for commercial insurance plans, or any insurance provider to exclude transgender care and surgery for patients that have medical need, as defined by the diagnosis of gender dysphoria. Currently, Medicaid and Medi-Cal and Medicare, Medicaid and Medi-Cal are the same thing, but in California it's Medi-Cal, and Medicare all cover gender-affirming surgery, and that's important for everyone to know. I'm surprised that so many patients that think they might need to pay cash for this. I've never, I've always worked at an academic center, so I'm on a salary. I don't handle or get cash. But no patient of mine has ever had to pay for anything, even with a medical center. So it's covered.
How long of a wait, though?
To get surgery?
To get approval for that, because,
Well, it depends on the insurance plan, but a big driver of the wait is if you go to a surgeon that knows how to can document that the individual meets all the criteria, I don't think it's very long. In our experience, Medi-Cal's approving stuff within 2-3 weeks. Yeah. But it's got to be done correctly, right? When the paperwork gets sent to Medi-Cal, if it's a,
But the question is where do you go to get it done?
Well, the surgeon does.
I know, but there are not very many surgeons who do that.
Okay, yeah.
Yeah, I mean, you're talking.
So you would go to your transgender special provider that might have a patient navigator or a patient advocate to help you with the pre-authorization and the referrals if you're on Medi-Cal.
Yeah.
So, and then the only Medi-Cal program in LA County that really has a robust, progressive trans program is LA Care. They're really excellent. So we always recommend patients at my previous clinic, St. John's, to go to LA Care because they have a trans program who approves surgeries within 3 to 4 weeks.
There shouldn't be a long wait. I know that some surgeons advertise waits of 2 years and whatnot. I don't know. In my experience, patients always tell me they can, some can get in a lot quicker with different things. At least at our center, I keep it flexible because I do a lot of tertiary care surgery. People that have urgent needs because they've had problems after other surgery. So I can always squeeze people in quicker. The wait at my center is anywhere from a couple to 6 months at the very most. And if it's urgent, we can get it done within a month.
So how many surgeons in the state of California are actually performing the phallic work?
Well, that's a good question. So I'm doing research to answer that question right now. But I can tell you, just from knowledge, the centers are Cedars-Sinai, Kaiser, Southern California. I don't think it's really started yet. They're going to.
They don't.
NorCal, they don't even do it. They do part of it in house, but the making of the penis they've contracted with a private surgeon.
You said North?
Yeah, Dr. Safa. And then there's a couple of other grounds. Curtis Crane moved to Texas. I think there's Satellite. He doesn't do phallic. Yeah, he just doesn't. So I think there's about maybe 3 providers in the state that are doing it. So it's not many, and it goes downhill when you leave that. Go ahead.
I just was curious how where you get the extra urethra from?
Oh, for the penis?
Yeah.
Oh, remember I was showing you that I leave a long strip of skin that's got a blood supply from the radial artery. That strip of skin is the urethra. And then I use a little bit of the bottom skin, so that the skin between the opening of the current urethra to the base of the penis, I use vulva skin, which is hairless. It has a good blood supply. All right, let me move forward here. We'll definitely have time for questions. I think they're really important to answer, to discuss. Institutional challenges. it's very important to build a culturally sensitive practice. As any of us who built practices and as any of us that are patients, first step one is you don't want to go to a place where you don't feel welcome or treated with respect. So before when I started UCSF's program and then our program at Cedars, I didn't start operating for a while. I had to make sure that everyone was up to speed on cultural sensitivity. So, the lessons this is more for providers and medical students and people who kind of come at this from the provider perspective. We have to expect to see transgender patients. And then if you expect to see transgender patients, then the next question is, well, you have to accept that everyone has a preferred pronoun. We just never think about it. But, everyone is a Mr. or Mrs. or Miss or something. And therefore you have to ask. We have to adopt strategies for respectfully identifying transgender patients in our clinic, having forms that ask for preferred name, preferred genders, preferred pronouns, having ways to identify patients as there for gender dysphoria related issues without being labeled transgender. No one wants to go with a big label on their forehead. So there's lots of subtleties to that. But I encourage my colleagues to ask preferred name, identified with preferred pronouns, and that can be asked in a respectful, nice way. And I think people appreciate that. I think it's important to use diagnosis codes that capture our transgender patients. Otherwise, how do we track our volumes, who they're seeing? This is very important. And then electronic medical record is a huge effing nightmare. The problem is that these damn electronic medical record companies like Epic, the relationship is chained. Like they think that we're the customer, or that they're the customer. They're doing us a big favor. They're very resistant to changing things, and it's like, so I'm waging full-scale war with them to get them to change our medical record to allow the preferred name to be within the legal name. See, in electronic medical records, the name at the top of the banner, which is what everyone looks at, has to be the legal name. With law, there's some legal issues with that. So it has to be there. But it's very misleading when it says John and the person identifies as a woman. So my strategy at UCSF was putting it in the middle of the legal name, in parentheses, with the understanding that anything in parentheses is not legal. But they're pushing back. We did it at UCSF, and then Epic has changed. Now won't do it. And we're fighting about that. But we have to get the medical record to, however we do it, to easily and quickly and unambiguously reflect someone's preferred name and preferred pronouns. Capacity building. It's very important to be training faculty, fellows, residents, our medical students, everyone in this area. And then I think we just really need to promote an interdisciplinary model. So when I started the program at UCSF, I didn't know better, and I kept saying this has to be a multidisciplinary program. And it was multidisciplinary. So one of my mentors there said, Maurice, consider the term interdisciplinary. And I said, well, what's the difference? And they said, interdisciplinary reflects that you all work together. Multi is like, it's simply a multi-service center. A department store is multi-wares, But it doesn't mean that the departments are working together. So even though we were interdisciplinary at UCSF, calling it interdisciplinary calls attention to that. And that's why when I started the program at Cedars, I sort of went at it a little differently in the naming. I keep emphasizing it has to be interdisciplinary. We all do work together, we do research together, and we communicate together with patients. Right now, Cedars, I'm very proud of this program. It's the only academic center program in the state that offers genital surgery. UCSF still has, and UCLA I know has a gender program, but they aren't really offering genital surgery. Genitals, some do orchiectomy, but that's not quite the same. I want there to be. I'm bragging about it, but I want us to not be the only ones. We can't. Especially, Cedars is, the irony is that Cedars, for a private institution, it's a private nonprofit, it makes gender surgery more publicly available than any public institutions, and that shouldn't be that way. We all pay tax dollars for the UC system to have programs, so I think it's kind of, it's not good. There's only 2 academic programs west of the Mississippi, ours right now, and OHSU. I'm helping train someone at UCSF, but when I left, there was no one to replace me, so we're still the only one, although now I'm at Cedars. But we have to have more. And I think it's also bad that private university hospitals with a lot of money that also get a lot of state funding don't do this. I don't say they don't do it for nefarious reasons or with malintent, but we have to kind of chop. We have to catch up. So USC, Stanford, all these these prestigious institutions, there's no reason that they shouldn't be serving this community. So what is, in an interdisciplinary model, I've already emphasized that there's people working together. Our program, we offer a spectrum of surgery. Genital surgery, of course, but facial, chest, gynecologic, voice surgery. There isn't a surgery that's offered to transgender patients anywhere in the world that you can't get at Cedars right now. I work hard to just, there's a lot of expertise already there, and I've brought everyone together. Of course, we offer primary care, hormone management, gynecologic care and surgery, mental health, endocrine, derm, voice, geriatric care, a very important area that I don't hear enough chatter about. And then also very important, pediatric and adolescent care. Children's Hospital LA is a fantastic institution. Dr. Olson is a fantastic provider and scientist and physician. And they have a huge transgender population of youth. The problem is that when youth time out of pediatric care, they have nowhere to go. And if they haven't made arrangements to meet adult providers, it's sort of like when you graduate and you have to go from middle school to high school and you've never, you know what I mean? It's like you don't know where to go, and it's very disorienting. And add to that the fact that, at that age, we're all kind of a little dopey, we're not the best, you know what I mean? And if they have parents that aren't involved, they're even more limited or more at risk for, so, what we're building is our partnerships where I educate, just even seen their adolescents in clinic long before they want surgery, just so they know options, they can plan and think. And then if they want surgery, we operate on youth as well, obviously with a much higher standard of care. It's a vulnerable population. We involve many of the doctors, including the team from CHLA or anyone else, but we do offer surgery for them. And I think, an interdisciplinary program has to be founded in part on research, education, and training. That's what, that translates to academic scholarship and leadership. And I've got these collaborations with colleagues from UCI, UCLA, Children's, and UCSF, and so forth. Another point I try to make, and I'm almost done here, is that I think trans care really calls on our, that old phrase about our better angels. It really does summon, to provide good transgender care, you have to put into action the skills that really define being a really good doctor, which is compassion, advocating for patients, and an eye towards innovation. How can we make care better for the people sitting in my office? And historically, let's be honest, have been very underrepresented and undercared for by the medical community. Trans surgery, the other thing I sold, I emphasized to Cedars when they recruited me, is that, look, trans surgery, when you get good at it, it brings innovation that in turn you can provide to non-trans patients. So I do vaginoplasties for cisgendered women who've lost their vaginas from radiotherapy. There's no one else doing that. So you can take the skill set, so trans care enriches us as people, as providers. It enriches a medical center because it brings greater expertise to offer everyone. And I think it's a nice way, it's PR, not for the sake of PR, which is sort of baloney, but it channels a message that many institutions deep down really believe in and feel, which is their commitment to diversity. The problem is if you just talk about it, it sort of doesn't really cut the ice, but when you have programs that demonstrate a commitment to diversity, talk about it. Whether it's ethnic diversity, socioeconomic diversity, gender diversity, and so forth. And that's why Cedars is very happy with me, and I'm very proud of Cedars because, I'll give you an example. When I came to Cedars normally is not in network for much Medi-Cal at all. And when I came down, I said, look, I'm going to still be the only provider of Medicare, vaginoplasty and phalloplasty under Medicare, I can't go to an institution, they won't let me do it under Medicare, or they would under Medicare, but Medi-Cal. So I said, look, we have to, we're gonna be the only providers of a rare service. We have to bend our own rules and make it available to everyone. And they let me offer genital surgery to any Medi-Cal plan. And that's remarkable. You see schools that don't do that even for non-trade.
How about referrals for TRICARE? I know military,
On it.
general surgeries is a big thing, and
We're
we have a
treating-
president who just knocked down transgender coverage.
Well, he badmouthed
He tried
it,
to, but-
but the military has stood against him. So right now, and this is a shocker, the active military is, meaning people in the military, active duty military service members can get genital gender-friendly surgery. The military's paying for it, and we're treating them at Cedars. Some are going to OHSU as well. No one's done the surgery yet. I'm scheduled to do what I think is going to be the first fellow at the end of this month. It's a, think military, think bureaucracy, paperwork, it's a nightmare. It's very slow, the paperwork, but we're doing it. So I take care of patients with TRICARE from the VA system, and then active duty. So
And you say every county in California?
there's no county we will turn away. We put a letter of agreement together. So I've got patients from, Ukiah, like every corner of the state. In fact, I'm getting patients from Nevada, Canada, the East Coast. I get patients from all over the country.
I'm talking specifically Medi-Cal, because that's a county.
Specifically Medicare.
Administered.
Yeah, and you have commercial insurance, you can go anywhere.
Right, exactly.
Yeah, it's Medi-Cal and Medicare. Medicare's federal, so I do Medicare patients from all over the place. But even the Canadian Medicare system, which is not called Medicare, but what was that?
It's the Medi-Cal patients that where you really struggle because you have such a hard time to find specialists who will
Yes.
do anything for them.
Does everyone understand that? No one wants to provide, specialists typically don't provide Medi-Cal.
I mean, you can put that on paper. You now have to offer it via ACA. But understand, please, who doesn't know the system, if no provider wants to do it in that specialty, you still can't get it.
You still can't.
So that's.
Does everyone get
that's
it? The
why
law says you're
I asked
entitled
the
to it,
question. Yeah.
but that doesn't mean that they're gonna provide it for you.
And where we're gonna do it in your kitchen?
And that's why transgender care, I don't mean to say it should only live in the academic realm, but it has to at least be in part living in the academic world, because if you're in private practice is business at the end of the day. And if it doesn't pay well, they're gonna take the commercially insured and maybe even Medicare before Medi-Cal.
Let me throw this at you.
It's law of the jungle, or
As
it's
an
nature.
argument for you, you realize that a lot of those institutions that do not do the transgender surgeries, they will happily operate on your PSD diagnosed child, whether they are newborn or a little bit older, and do any kind of gender assignment surgery for them, covered under insurance,
Right.
on a non-consenting child.
Yeah, I get it.
So-
It's ironic.
I'm
And it's
just
not fair.
saying,
Yeah.
to open the discussion is to say, well, you're offering this,
Yeah.
so wouldn't it be just as logical to offer that?
Yeah. The counter argument is that we don't want to start denying kids surgery. Yes, I agree that the lack of consent is another problem, but yeah, we just have to open it up. And I think public institutions have to just take responsibility. They can't cherry pick. They cherry pick, and then we go into a society where we have a two-tiered system. You get all the care at the fancy pants, but and honestly, a private practice is not as good as an academic center, and often as an academic center anyway. I mean, there are some excellent private practice surgeons. I'm not bad-mouthing the individuals. It's the model. An institution when you need a kidney transplant, you don't go to a strip mall. You go to a big an academic medical center. So anyway, you had a quick question.
Their comment was just absolutely on target. I had all my gender confirming surgery as intersex surgery.
Yeah.
Once you get the slightest intersex history or anything on your medical record, you qualify. Any.
Yeah, but I mean that's good for you. I just think it doesn't just. it muddies the water. It's like we should call a spade a spade. If we're doing it for gender dysphoria, let's just say
Okay,
gender
I
dysphoria.
agree.
Yeah. Otherwise, we never quite get out of the system we want to change. We keep making adjustments, I think. But all right, we'll speed up to the very last slides here. Practical challenges: we have to offer care in an environment that minimizes dysphoria, for whether it's cancer screening, prostate, stuff like that. We have to ask about sexual function. And then clinical unknowns. There's a lot of unknowns. These are just a handful of things. The long-term durability of phalloplasty, urinary tract function, STDs, sexual function. That's not being well looked at. I'm following it, but there's not a lot of publications in this. So, cancer risk. We know that trans women, anecdotally, everything suggests they're at much lower risk for prostate cancer, but it's not zero risk. So what do you tell the transgender woman whose father and brother had prostate cancer? I tell them, we don't know, but we should err on the side of caution and just screen you like we would, regularly. There's no harm to rectal exams or transvaginal prostate exams if they have a condition. We just have to be honest, and I feel very comfortable saying I don't know the answer to this. But because I care about you, let's err on the side of being a little bit extra cautious, And then if it becomes a problem, let's discuss it and see what we can work out. STD and HIV transmission risk through skin, the vaginas, especially intestinal. I worry about the intestinals because, the intestine is such it's so absorptive. You can put a suppository in the rectum and it gets in the body, so I worry about that. But we don't know the answers to that. I'm not seeing any problems from it. The long-term safety of hormone therapy, we submitted an R01 grant looking at this. We're looking at it. Dr. V had some great points about this as well. What are the target parameters to guide hormone therapy dosages? And then all these other things, spironolactone, estrogen, progesterone, 5-alpha reductase inhibitors. My colleagues have already made a lot of good points about this. What are the best practices for managing gender dysphoria in children? Certainly my pediatric colleagues can answer this, but it's for the people as they transition to adulthood, I think there's a little less data because there's no one really following this. So there's a lot of, there's a lot to look at and do here. And then fertility, quality and fitness of the gametes. Dr. V's slide, talking about some of the metabolites of estrone can cause DNA damage. I wonder, can that affect sperm quality? No one's looked at sperm quality on hormones. Yes, there's less motility, but some sperm do move. Can we use, we need more granularity. And then heritability. I had a patient who, just chatting, she mentioned her trans sisters and then her trans brother, and I said, how many folks in your family are transgender? And she had, of 6 siblings, all biological siblings, actually seven kids or adults. There were 6 boys, 6 children born as boys. 3 out of the 6 are trans women. And one of the birth sex girls is a trans man. And here's their picture. What state, does anyone know what state has the most per capita transgender people? I'll buy a cup of coffee. Hawaii. Hawaii. Hawaii's the right one. Clean your coffee. Isn't that interesting? California is only the second. And these people are from Hawaii. Opportunities for innovation. I have like 2 or 3 slides. How can we, decision-making tools for patients? There's a big need for that. Managing expectations. Using artwork like the Great Wall of Vagina to make these points, I think is useful to people. We have to bring this in. We have to be creative. And that's why, the diversity of people that are part of WPATH, you find people that are artists and psychologists, and everyone has good ideas. I work on surgical device design. I'm working with the company that makes the penile prosthetics to make them designed for trans male anatomy. There's my Dr. Garcia dilator douche. There, it's longer, it's got a hole at the tip, and it's got depth markers on it. Mine is the one on the right. We just have to kind of improve on things. We shouldn't, you know, trans patients and those of us that provide care to them shouldn't be satisfied with, you know, what we do for the system. You know, we come up with our own stuff. I've given talks about using cadaveric tunica, which is basically the inside of the penis, when we do phalloplasty to better anchor the penile prosthesis, basically remaking a penis. It's cadaveric though, so it comes from cadavers, but it's acellular, and there's a company interested in this. So there's a lot of good things we can do. Strategies to improve cosmesis. So here's a patient on the far left. Those are those kind of, I mean, I don't want to be pejorative, but I think, I haven't had a patient yet who said, I think these scars on my leg are beautiful. They really don't like them. Some are indifferent, but they're not nice. These are the split thickness skin graft scars. You see a lot of these online on blogs. And in our surgery, what we do with the butt, you know, there's a steri strip here, because this is on the day of surgery, but it's just a little crease. You have to kind of pull the butt apart to even see the scar line. So it's much nicer looking. So we have to be very thoughtful about that. And then do research. I mean, I give classes on surgery, I do cadaver research. Here you see, you know, a bisected cadaver where the vaginal canal is. There's so much to learn. And if you like research, this is a wonderful field. And why I'm so satisfied in doing it, not only is it work I believe in, but it's from a kind of personal, scientific-y kind of what you like to think about way. It's just, I find it fascinating. And then we providers have to provide literature to share with patients and other providers to make for more culturally sensitive care, for better information, trying to stamp out misinformation. You know, Dr. B, you know, her talk and your talk, there's a lot of unknowns, and people, when everyone's saying something different, it's kind of, as a patient, I'd be like, Jesus Christ, you know, there's no single story here. And it makes you kind of question who's right. So anyway, in conclusion, transgender patients are a large, vulnerable, and very grateful patient population. This is a fascinating field, and there's lots of opportunities to collaborate. This is my cell. If any of you ever have any questions, that's my email. I'm happy to talk, and I'd love to collaborate. And thank you. Okay, 5 minutes. So I can keep answering questions offline. You.
On the bilateral orchiectomy, is there a certain amount of time that you are going to have the confirmation surgery that you should have so you don't have more atrophy in the skin on it? Will it continue to atrophy?
No, I don't believe the skin actually atrophies. I think without the testicles, there's a lot of elastin in the skin of the scrotum, which is just a protein that looks like little springs that makes it elastic. I think without the testicles, it shrivels up, but it's still there. It hasn't actually shrunk. Yeah, like spandex or something. Yeah, you.
Yeah, it's my understanding that the phalloplasty has a 65%, 70% failure rate. Is that true?
So, well, it depends
because
on how you define failure. So
Yeah.
the penis, you know, turning black and falling off, I think it's, I've not, you know, had it, but I would say it should be no more than 2%. You know, blood vessels can get blocked, this, that, and the other. Complications from the urethra, that's where all the complications come from. And I think, you know, I've heard 60%. In my practice, it's about 20%. But that's the stricture. Then we deal with it, and, you know, all my patients, we end up moving forward and getting through it. But it is not a surgery that you should expect to sail through and have no problem. You know, there's a high likelihood we'll have to come back and work on something. In general, 60%, 70%. It is high complication rate. Now, what contributes to high complication rates, in others' hands, is doing it all in one stage. So the beauty of doing it in 2 stages is that the penis and the urethra that I've just made never see urine for 4 months. So by the time they start seeing urine, they're healed better. I think that's why I have better complication rates than what's quoted in the literature. But we have to be, you know, thinking about that. So that's where you see a lot of variation. You had a question.
I've read a lot of studies about having a vasectomy. You could create less testosterone in your body without having to remove them at first. Do you know anything about that?
I don't think that's at all accurate. I don't think vasectomy should have any effect on testosterone. You don't have sperm in your ejaculate. That's not the only thing. as testosterone.
I just hear a lot of Canada research.
No, and that's what
produces less.
That's what I mean. There's a lot of like this, you know, I don't know where that stuff comes from, but there's no scientific basis for
Okay, thank you.
that. Yes.
How many cases of gender affirmation surgery do you do annually, and do you ever have students in?
I do have students, and I love having students. It's fun, and I end up working with a lot of them on little projects and stuff. So your students are always welcome. I have a lot of students from UCLA and UC Irvine that are coming over, and UC Irvine knows that. So email me, and then I'll give you a little observer package. You have to just provide evidence of immunizations, and then something that says you're a medical student or anything, and then you can come in. How many we do, I mean, I've only been doing it at Cedars for about 9 months, but I do about 3 major surgeries a week. Mix of male, female, female, male, and they vary week to week, but you know, 3 or 4 vaginoplasties or phalloplasty or 1 vaginoplasty or something like that, revision surgeries. Because I do I do all types of surgeries, primary and revision. It's all a mixment. It is a lot. But we're going to have to get someone else to. Yes.
I was wondering if you do kind of like the Meltzer model where you do a vaginoplasty and then 2 months later you do a labiaplasty. And if you
That's a good
don't,
question.
How do you get in?
I don't believe that vaginoplasty has to be done in 2 stages. I will say that I tell my patients, women that I see, there's 1 in 10 of you is going to need a second little surgery after, and it's really just perineoplasty. Some of the skin from the perineum can migrate anteriorly and block the vaginal opening. It's a short 20-minute outpatient surgery, but everything can be done in 1 stage.
Including inner and outer labia?
Yeah, there's no reason, you don't gain anything by waiting on it. Most surgeons do it in 1 stage. Meltzer, I don't know why he does it.
We're hearing more about bioengineered, parts. I'm wondering what's the timeline, because you're obviously a nerdy academic type.
Yes.
You're probably looking at that.
Yes.
Where's that in the pipeline?
Well, the problem is, where is that in the pipeline? Where is any bioengineered stuff? We're still not making kidneys and livers and all that. I think we're a ways away. I think in general, reconstructive surgery, we should come to that a little sooner. When it is, I don't know. But like the stuff that I'm proposing, getting FDA clearance for that in a year or 2. But at least in reconstructive, we don't have to make a whole organ necessarily. We just have to make tissues that you can use, like material, like cloth. And there's a lower bar for that. But it's still, anything you do is FDA, and it's a slow process. I think we're moving faster than we are for engineering for other things, like kidneys, livers, eyeball.
I was just thinking in terms of the quality of outcome in female to male as opposed to male to female. It seems like the male to female outcome seems like an overall better
It's
outcome.
definitely.
And
There's a lot of limitations to
transgender
follow.
men are still left wanting function.
Yeah, that's a true statement. Diane.
How many trans-identified folks do you guys have working with your program?
We have, so providers, we have about 20 in all those groups, maybe even more. These are leads. So someone from Durham is the lead. Plastic surgery, he's the lead for his group. But I'd say about 20 who are consistently active. And then a lot of other, in mental health, there's a bunch of different, the numbers get a little bit bigger, but a little less active. But 20 core people. It's a big program. Anyone else? I'm free outside. I don't want to make the next speaker late, so thank you so much. It's been a pleasure.
Thank you, Dr. Garcia, one more time.